Welcome to the Wednesday webinar. We'll just give people another 30 seconds or so to join, and then we'll start. Good afternoon, and welcome to the National Bleeding Disorders Foundation Wednesday webinar. My name is Fiona Robinson, and I'm your host today. In today's webinar, we will learn about understanding recombinant factor IX FC efficacy and outcome data. We would like to extend a special thank you today to Sanofi, whose generous support made this webinar possible. This webinar is being recorded. The recording will be available shortly after it ends on the NBDF website, bleeding.org. We encourage you to ask any questions you may have today. You can ask your question by using the Q&A feature at the bottom of your screen. We will monitor these questions as you post them, and then following our speaker's presentation, we will put your questions to them. Today, we are joined by Dr. Amy Shapiro, Medical Director and CEO of the Indiana Hemophilia and Thrombosis Center. I'd like to thank Dr. Shapiro for joining us today, and I will turn things over to her now to get us started.
Thank you, Fiona, and thank you very much, NBDF, for inviting me to do this presentation. And thank you, Sanofi, for the working together to create this information for you. Again, today we're going to speak about recombinant factor IX FC, efficacy, and outcome data. These are my disclosures. Just some disclaimers to start. The information that I'm going to discuss is not intended to provide medical guidance or recommendations to any particular individual with hemophilia. And of course, as always, we recommend that you speak to your treating physician about any questions you may have about your disease management and treatment options. My goal today is to provide some factual information about recombinant factor IX FC therapy, including clinical data that was obtained from studies. The program is non-promotional. It is sponsored by Sanofi. The institution that I am affiliated with is being compensated for my presentation today. The content of the presentation was jointly developed by myself and Sanofi. Unfortunately, it is not eligible for CME credits. And of course, the presentation is not meant to convince you to use any particular manufacturer's products, including Sanofi. Is just meant to present the data that was obtained and published and widely available. My objective today is to review the post hoc analysis from the phase 3 clinical trials utilizing recombinant factor IX FC in previously treated patients, as well as previously untreated patients with hemophilia B. The two main manuscripts from which the data has been pulled for today's presentation of these post hoc analyses are listed here. And thank you, Fiona, for putting them in the chat as a link so that they are available to the audience as well. There are 3 studies that contributed to the post hoc analysis for the previously treated population, including the B-Long trial, Kids B-Long, and the long-term extension study that included these studies, which was called Beyond. The initial B-Long study was an open-label, non-randomized, multi-center phase 3 study that evaluated the safety, efficacy, and pharmacokinetics in previously treated patients with a baseline factor IX level of less than or equal to 2%, without a history of an inhibitor, who were greater than or equal to 12 years of age and treated either on prophylaxis or who had greater than or equal to 8 bleeding episodes in the year before enrollment, as well as greater than or equal to 100 exposure days. Kids B-Long was an open-label, non-randomized, multi-center phase 3 study that evaluated the safety, efficacy, and pharmacokinetics in previously treated patients with a factor IX level of less than or equal to 2%, also without a history of an inhibitor, who were less than 12 years of age and had greater than 50 exposure days. The BEYOND trial represented the long-term extension study in patients who completed either B-LONG or Kids B-LONG and who desired to continue treatment with recombinant factor IX FC. The PUPS B-LONG study was an open-label, single-arm, multi-center phase 3 study that evaluated the safety and efficacy of recombinant factor IX FC in pups. The population included male individuals who were less than 18 years of age with a factor IX deficiency level of less than or equal to 2%. Hemophilia B is an X-linked bleeding disorder characterized by a deficiency of coagulation factor IX. Affected individuals may have varying levels that place them in either the severe, moderate, or mild deficiency range. Like hemophilia A, individuals with severe hemophilia B present with recurrent spontaneous bleeding episodes, particularly affecting but not limited to joints and muscles. For both severe hemophilia A and B, prophylactic replacement therapy represents the current standard of care for bleed prevention. Today, we are reviewing data on recombinant factor IX FC fusion protein, an extended half-life factor IX replacement, which is used for both prophylaxis and on-demand treatment, as well as surgical management of hemophilia B. Let's first review the post-hoc longitudinal assessment of the efficacy and safety of recombinant factor IX FC fusion protein in hemophilia B that included the 3 studies I previously mentioned, the B-LONG, Kids B-LONG, and BEYOND studies. The purpose of this study was to conduct a post-hoc assessment of the longitudinal efficacy and safety data for prophylactic factor IX FC regimens from a phase 3 clinical trials in previously treated subjects, including those treated with dosing intervals greater than or equal to 14 days, and those with target joints at baseline. Here is a graphic representation of how the B-LONG and Kids B-LONG studies were conducted and how these studies folded into the BEYOND study. The B-LONG study included 123 individuals treated on one of 4 treatment arms, including weekly prophylaxis, individualized prophylaxis, on-demand therapy, and perioperative management. Individuals in the study could switch treatment arms at any time. The Kids B-LONG study had one treatment arm consisting of weekly prophylaxis. When these 2 main studies reached their endpoints, participants were offered longer-term treatment through the BEYOND study, which was an open-label, non-randomized global extension study. Here again, participants could opt for one of 4 treatment arms, including weekly prophylaxis using 20 to 100 units per kilo every 7 days, or individualized prophylaxis using 100 units per kilo every 8 to 16 days or twice monthly, or modified prophylaxis, which consisted of dosing tailored to meet the needs of those requiring more personalized dosing and not fulfilling the definitions of individualized weekly or on-demand regimens, or the last dosing regimen, which was on-demand treatment, but only for participants who were greater than or equal to 12 years of age. Overall, the recommended starting regimens of recombinant factor IX FC dosing for routine prophylaxis were for adults and adolescents greater than or equal to 12 years of age to receive either 50 units per kilo once weekly or 100 units per kilo every 10 days. And for children less than 12 years of age was to start with 60 units per kilo once weekly. The dosing regimen could be adjusted based on the individual response. More frequent or higher doses may be needed in children less than 12 years of age, especially in children less than 6 years of age, due to differences in pharmacokinetics. Here are the dosing regimens for the B-LONG, Kids B-LONG, and the BEYOND extension studies displayed in a table, showing which treatment regimens or arms were permitted in each study. The outcomes analyzed in this post hoc analysis included the cumulative duration of recombinant factor IX FC exposure, recombinant factor IX FC consumption as measured by the total number of IU per kilo per subject per year, the longitudinal overall ABR or annualized bleeding rate, the annualized joint bleeding rate or AJBR, and annualized spontaneous and traumatic bleed rate. We also looked at the number of exposure days and the change in dosing interval. There was also a longitudinal analysis of pooled data from BEYOND that was performed and included 3 sub-analysis populations. These 3 sub-analysis populations that were evaluated included 1, subjects who remained on weekly or individualized prophylaxis until year 5 of the study. However, for children, this was until year 4. 2, subjects who ever received factor IX FC prophylaxis with a dosing interval greater than or equal to 14 days. And for 3, subjects with target joints at entry into B-LONG or Kids B-LONG who received prophylactic treatment. The baseline characteristics of the 3 study populations are shown here, with the 2 main trial participant contributions to the long-term extension study of BEYOND. Of interest, the majority of participants, 66, in the B-LONG study had been treated on a prior on-demand regimen, while 41 were treated on prophylaxis prior to entry. The age range of this study included individuals ranging from 12 to 71 years. The treatment arms used in B-LONG are shown at the bottom of the table on the left. In Kids B-LONG, there were 30 participants, all treated with a prior prophylaxis regimen, who ranged in age from 1 to 11 years. Most participants in both trials participated in the BEYOND study, which included 120 individuals with their respective treatment arms shown again in the bottom of the table on the right. Looking at the B-LONG and BEYOND pooled analysis, the median exposure to recombinant factor IX FC was 3.63 years, with a range of 0.003 to 6.48 years. This encompassed a median of 165 exposure days, with a range of 1 to 528 exposure days. For the Kids B-LONG and BEYOND pooled analysis, the median exposure to recombinant factor IX FC was 2.88 years, with a range of 0.3 to 4.8 years, including a median of 166 exposure days, with a range of 18 to 256 exposure days. Overall, in the B-LONG trial, the annualized bleeding rate over time for those treated on weekly prophylaxis, represented by the green bars, and individualized recombinant factor IX FC prophylaxis, shown in the purple bars in the left graph, was low and showed a trend to further decrease over longer-term treatment. In the Kids B-LONG trial, all participants used a weekly prophylaxis regimen with a resultant ABR of 2 or less that again tended to decrease over further time on treatment. These 2 plots show the pre-study and overall ABR for the participants treated with weekly and individualized recombinant factor IX FC prophylaxis. The left graph includes data from the B-LONG and BEYOND studies. The ABRs for pre-study treatment for weekly and individualized prophylaxis is shown in the red box, with the ABRs on study treatment with recombinant factor IX FC for B-LONG and BEYOND individually, and for their pooled data in the last section on the graph. The same data is also shown for the Kids B-LONG and BEYOND studies on the right graph. Here again, all participants in this study used weekly prophylaxis. These data show that ABRs remain consistent for weekly and individualized recombinant factor IX FC prophylaxis at the end of B-LONG, Kids B-LONG, and beyond. In addition, individualized interval or weekly prophylaxis adherence rates were pooled across B-Long, Kids B-Long, and Beyond studies and showed that there was a high adherence rate for prophylactic regimens across the parent and extension studies. Now let's look at overall consumption of product, which is reported as the number of IU per kilogram per year. Again, the red box shows the annualized consumption overall prior to entry into the parent study. This data is shown for weekly prophylaxis and individualized prophylaxis for the B-Long study and for weekly prophylaxis for the Kids B-Long study. Consumption remained consistent throughout years 1 through 5 for the B-Long study and years 1 through 4 for the Kids B-Long study. Overall, consumption was lower than that utilized by participants prior to study entry. These graphs show the ABR and factor consumption for subjects who remained on weekly prophylaxis for 4 to 5 years. The graph on the left shows the overall ABRs, which were maintained across all age groups and were low without an increase in factor consumption, which is shown on the right plot over the number of years on study. The median and interquartile range for the dosing interval remained the same from the start of B-Long and Kids B-Long to the end of Beyond, and among subjects who remained on weekly prophylaxis and was 7 days. Subanalysis 1 also included the ABR and factor consumption for subjects who remained on individualized interval prophylaxis for 5 years and included 17 participants. The low ABRs were maintained among B-Long subjects remaining on individualized recombinant factor IX Fc prophylaxis for 5 years without an increase in factor consumption. The median dosing interval was extended from 10 days at the start of B-Long to 14 days at the end of Beyond among subjects who remained on individualized prophylaxis. Subanalysis 2 comprises the participants with a prophylaxis dosing interval greater than or equal to 14 days at any time and included 23 subjects with demographics shown in the left table. These 23 subjects were treated with a greater than or equal to 14-day dosing interval at any time during the B-Long Beyond study, with 83% on individualized prophylaxis. 87% of subjects had a baseline factor IX level of less than 1%, consistent with 82% in the overall B-Long population. The median terminal half-life was 98.7 hours, with a range of 60.6 to 118.2, compared with 76.9 hours, with a range of 37.8 to 135.2 among those without a greater than or equal to 14-day dosing interval at any time. The recombinant factor IX Fc exposure for participants with a prophylaxis dosing interval greater than or equal to 14 days at any time is shown on the left, with a comparison to their data before the first greater than or equal to 14-day dosing interval shown in the red bar. The dosing interval distribution for these 23 participants is shown in the right graph. The majority of subjects, 16 or 70%, remained on a greater than or equal to 14-day interval extended dosing regimen. 6 subjects extended their dosing interval to greater than or equal to 15 days at any time, with 1 subject who extended the dosing interval to greater than or equal to 21 days. 3 or 13% of subjects switched temporarily to a less than 14-day dosing interval, and 5 subjects returned to a dosing interval of less than 14 days at the end of the study. There were 142 bleeds reported in these 23 participants with a prophylaxis dosing interval of greater than or equal to 14 days at any time. 95% of these bleeds resolved successfully with less than or equal to 2 infusions. The low median ABRs were sustained after extending the dosing interval in subjects who received prior prophylaxis, that's 19 patients shown in the purple bars, whereas in the one patient treated with prior on-demand therapy, the ABR was higher during his extended dosing interval. Of the 23 subjects who were treated on study with a prophylaxis dosing interval greater than or equal to 14 days at any time, 16 did not change their interval. 3, or 13% of subjects, switched temporarily to a less than 14-day dosing interval, and 5 subjects returned to a dosing interval of less than 14 days at study end. The reasons given for these changes, including the occurrence of bleeding events, change owing to a PK result, individual request, and others as listed in the table. The adverse event profile among those on a greater than or equal to 14-day dosing interval regimen was consistent with previous studies. Sub-analysis 3 included B-long or beyond prophylaxis subjects with a target joint at entry into B-long. Among the 117 subjects enrolled in B-long study with available on-study data, there was a total of 166 target joints in 60 participants, with 51% of this group having greater than or equal to 1 target joint at baseline. The knee was most commonly affected joint, with 42 participants, or 70% of those with target joints, experiencing issues in this joint. In these 60 subjects, weekly prophylaxis was used in 41, individualized prophylaxis in 13, and modified prophylaxis in 13. The recombinant factor IX FC average weekly dose for the 3 treatment regimens is shown on the right. This table divides the data for those with target joints at entry based upon their prior treatment regimen, either prophylaxis or on-demand. Their on-study treatment regimen is shown below, and their on-study overall ABR and their on-study ABR spontaneous bleed rate in the pre-existing target joint. Overall, there were low median ABRs reported across all prophylaxis regimens for those with target joints at entry into B-long, and there were low median ABRs observed for pre-existing target joints among subjects receiving prophylaxis. Those treated on demand with prior target joints continued to demonstrate a higher ABR overall and a higher spontaneous AJBR in their target joint. In terms of resolution of evaluable target joints in subjects receiving prophylaxis in B-long and beyond studies, out of 37 subjects, all evaluable target joints were resolved among those on recombinant factor IX FC prophylaxis. The recurrence of target joints was low after initial resolution. Recurrence was defined as greater than or equal to 3 spontaneous bleeds in a single joint within any consecutive 6-month period after target joint resolution. In summary, in terms of efficacy, during up to 5 years of individualized and weekly prophylaxis, ABRs remained low across all age groups. Recombinant factor IX FC prophylaxis provided long-term, sustained improvement in joint outcomes in adults and adolescents. Weekly recombinant factor IX FC prophylaxis was the most used regimen in subjects with target joints, although individualized prophylaxis and modified prophylaxis were also used. All evaluable target joints resolved during treatment, and no recurrence was reported in 90% of baseline target joints during follow-up. In terms of the recombinant factor IX FC consumption, during up to 5 years of individualized and weekly prophylaxis, annualized factor consumption remained stable across all age groups. Subjects remaining on individualized prophylaxis extended their dosing interval from a median of 10 days at the beginning of B-long to a median of 14 days at the end of beyond. The majority remained on their extended dosing interval regimen. Regarding safety, no subjects developed inhibitors to recombinant factor IX FC in B-long, kids B-long, or beyond. There were no reports of anaphylaxis, serious hypersensitivity, or vascular thrombotic events during long-term treatment with recombinant factor IX FC. Additionally, it has been demonstrated that intervals can be individualized for patients to achieve a trough of at least 1 to 3% above their baseline level. There are limitations to this study, including the post hoc nature of the analyses. The subjects included may not be representative of a real-world cohort of individuals with severe hemophilia B, and the number of subjects included in analyses for 4 and 5 years and 14-day dosing interval is relatively small, thus limiting the conclusions that can be drawn from the data at these extended time points. In conclusion, this longitudinal post-hoc analysis of BEYOND demonstrates that the benefits of recombinant factor IX FC prophylaxis are sustained year over year for at least 4 years in children and 5 years in adults and adolescents. These results support the long-term efficacy and safety profile of recombinant factor IX FC and are consistent with the provision of sustained long-term bleed prevention and target joint resolution. Now let's move on to the post-hoc analysis of the PUPS BELONG study. The objective of this study was to report a post-hoc analysis of spontaneous bleeding events in the context of recombinant factor IX FC comparison groups among the previously untreated patients or PUPS BELONG study population to identify factors that may influence bleeds in PUPS with hemophilia B. This graphic shows the study design. Individuals with less than or equal to 3 infusions of commercially available recombinant factor IX FC and without inhibitors were eligible. A total of 33 males less than 18 years of age with a factor IX level of less than or equal to 2% were enrolled. Of this group, 18% had a confirmed family history of inhibitors, while 82% were unknown. Entered participants had an option for use of an on-demand treatment regimen or prophylaxis at an initially recommended dose of 50 IU per kilo weekly. Of the 33 enrolled patients, 22 started on an on-demand regimen, while 11 started on prophylaxis. Of the 22 who started with an on-demand regimen, 17 subsequently changed to prophylaxis, for a total of 28 patients ever on prophylaxis. 5 patients remained on an on-demand regimen, 6 discontinued the study, and 27 completed the study. 1 patient was withdrawn from the study because of a treatment-emergent serious adverse event of hypersensitivity and factor IX inhibition or inhibitor development, which were considered related to study treatment. There were 3 post-hoc groups defined for this analysis. The first group was analyzed by their starting regimen, meaning those that started on demand versus those that started on prophylaxis. Of the 33 patients included, 22 started on demand and 11 on prophylaxis. The second group was analyzed by treatment, meaning those ever on demand versus those ever on prophylaxis. In this analysis, 22 were ever treated on demand, while 11 started prophylaxis and 17 switched from on demand to prophylaxis for a total of 28 ever on prophylaxis. The third group was by type of prophylaxis, meaning those that started on prophylaxis, 11, versus those that switched to prophylaxis, 17. The outcomes for this analysis included the spontaneous bleed occurrence, the impact of baseline age as a predictor for time to first spontaneous bleed event, and the time to the first spontaneous bleeding event, which was stratified by treatment regimen or group. A statistical analysis was conducted to determine on average how long it took for patients to have their first spontaneous bleeding event based on if they were receiving on-demand treatment or prophylactic treatment. Overall, there were 24 spontaneous bleeding events that occurred among participants in the PUPS BELONG study, all of which were treated. 2 participants experienced life-threatening bleeds, such as an intracranial hemorrhage, while receiving on-demand therapy, both of whom switched to prophylaxis. A total of 5 patients were ever on-demand therapy. 4 were patients with moderate hemophilia and no bleeds, and the remaining patient treated on demand experienced bleeding events. The time to the first spontaneous bleed is shown here by starting regimen, meaning those who started on demand versus those who started on prophylaxis. Of the 22 subjects who started with on-demand treatment, 9, or 41%, experienced a first spontaneous bleeding event at any time, and 6, or 67% of these events occurred while treating with an on-demand regimen. Only 1 participant who started on prophylaxis had a spontaneous bleed, compared to 9 in the on-demand group. The participants on prophylaxis had a 93% reduced risk of a first spontaneous bleed compared to those on an on-demand regimen. The time to the first spontaneous bleed by treatment is shown here, meaning those ever on demand versus those ever on prophylaxis. Of the 28 subjects who ever received a prophylaxis regimen at any time, 4 had a spontaneous bleed event. 3 of these bleeds occurred in patients who started with an on-demand treatment regimen. Participants receiving recombinant factor IX FC prophylaxis had a reduced incidence of the first spontaneous bleeding event and a longer median time to first spontaneous bleeding event, 341.5 days, compared to those treated with an on-demand regimen, 183 days. The time to the first spontaneous bleeding event by type of prophylaxis, meaning those that started on prophylaxis versus those that switched to prophylaxis, is shown here. Of the 11 participants who started the study on recombinant factor IX FC prophylaxis, 1 had a first spontaneous bleeding event, whereas 3 of the 17 who switched from on-demand regimen to prophylaxis experienced a first spontaneous bleed. The median time to the first spontaneous bleed event was 374 days for those starting prophylaxis versus 309 days for those who switched to prophylaxis. The single first spontaneous bleed event in the starting prophylaxis group was a joint bleed. In the switch to prophylaxis group, 1 bleed was observed in a joint and 2 were skin or mucosal bleeds. In summary, early intervention with prophylaxis with recombinant factor IX FC in pups with hemophilia B can reduce the likelihood of a first spontaneous bleeding event. Prolonging the time that is free from spontaneous bleeding, particularly joint bleeds, may contribute to better future health by reducing the likelihood of further spontaneous joint bleeds. Despite a similar ABR between the on-demand and prophylaxis groups, which was likely due to the age of the population, the duration a patient is bleed-free is an important consideration when determining initial treatment plans. In conclusion, recombinant factor IX FC prophylaxis in previously untreated patients, particularly in those that started with prophylaxis, reduced the risk of bleeding and delayed the time to the first spontaneous bleed when compared with recombinant factor IX FC used on an on-demand regimen or for those who switched from on-demand to prophylaxis recombinant factor IX FC regimens. These results are limited to a small patient group, but suggest that initial treatment regimens and early intervention can impact bleeding patterns in pediatric pups. Again, these are the links that I believe were dropped into the chat for you. You can also click on these on your webinar slide, I believe, and get links to the articles that reported this data and from which this discussion was derived. This is some safety information for recombinant FC factor IX. The QR code there will link you to the full prescribing information. And again, there's a disclaimer that Sanofi does not provide medical advice, diagnosis, or treatment. The health information contained here is provided for general educational purposes. And again, your healthcare professional is your best source of information regarding your care and treatment regimen. Thank you for your attention.